Bubonic plague sounds like a disease locked in medieval textbooks, yet it remains a real infection with modern cases and modern consequences. It is caused by the bacterium Yersinia pestis and is one of three major forms of plague, alongside septicemic and pneumonic forms. What makes bubonic plague distinct is where the infection first takes hold, the lymphatic system. After exposure, symptoms can begin in as little as 1 day or as long as a week, often starting with fever, headache, weakness, and vomiting. Those signs are not unique, which makes early recognition difficult. But then comes the clue that gave the disease its name: swollen, painful lymph nodes called buboes, usually near the site where bacteria entered the skin. This is the turning point in the story, because the moment those nodes swell, the body is signaling a highly dangerous bacterial invasion. Understanding bubonic plague means understanding that ordinary-looking symptoms can hide a rapidly escalating emergency. The transmission chain begins far from hospitals, often in animal ecosystems where plague circulates naturally. Fleas feeding on infected small mammals can acquire Yersinia pestis, then pass it onward through later bites. Humans are usually accidental hosts, stepping into this cycle when flea populations shift or infected animals die, forcing fleas to seek new blood meals. This ecology explains why plague risk can rise in specific regions and periods rather than everywhere at once. Bubonic plague usually starts when bacteria enter through skin, then travel through lymphatic vessels toward nearby nodes. But route matters. If bacteria spread in blood, disease can become septicemic. If lungs become involved, pneumonic plague can emerge, and that form carries person-to-person respiratory risk. So plague is not one simple pattern. It is one bacterium expressing different dangers depending on pathway. The flea bite is the visible event, but the larger risk is the biological network behind it, linking wildlife, vectors, and humans in a chain that can activate quickly. Inside the body, bubonic plague is a race between bacterial spread and immune response. Once Yersinia pestis reaches a lymph node, inflammation escalates and the node enlarges, producing the classic bubo. These swellings are often intensely painful and can appear in the groin, armpit, or neck depending on where infection entered. In some cases, buboes may become so inflamed that they break open. While the bubo is the hallmark, it is not the full danger. The infection can progress beyond local nodes, entering blood and triggering severe systemic illness. Historical accounts and clinical observations include acral necrosis, dark discoloration in extremities when tissue perfusion fails. That dramatic sign contributed to plague's terrifying reputation, but the deeper issue is circulatory and inflammatory collapse. Even without obvious skin changes, patients can deteriorate fast. Bubonic plague therefore should not be viewed as only a swollen node illness. It is a potentially whole-body infection that starts locally and can become fatal if not interrupted early. Clinical diagnosis starts with suspicion, but confirmation requires laboratory evidence. Doctors look for Yersinia pestis in blood, sputum, or fluid taken from affected lymph nodes. This step is critical because many diseases can mimic early plague symptoms, and delayed certainty can delay life-saving treatment. Epidemiological context becomes part of diagnosis. Recent flea exposure, contact with dead animals, residents in endemic areas, or local reports of unusual animal die-offs all raise concern. In suspected pneumonic involvement, urgency increases further due to potential respiratory spread. Confirming plague does more than guide one patient's care. It activates public health mechanisms, case reporting, exposure assessment, risk communication, and targeted prevention. In this sense, plague diagnosis is both a medical and societal event. A single confirmed case can reveal broader ecological activity in the region. That is why surveillance systems matter. They convert isolated clinical encounters into early warning signals that can prevent larger outbreaks and reduce mortality across communities. Treatment is where modern medicine radically changes outcomes. Effective antibiotics include streptomycin, gentamicin, and doxycycline, and the key factor is speed. Without treatment, plague mortality can range from about 30% to 90%, with deaths often occurring within 10 days in severe cases. With prompt treatment, mortality can drop to around 10%. That difference is enormous and explains why plague remains feared but manageable when systems function well. Antibiotics are not the only component. Supportive care helps stabilize patients through dehydration, organ stress, and inflammatory complications while antimicrobial therapy works. The practical challenge is not only having drugs, but delivering them fast enough in places where access may be limited. In rural or resource-constrained settings, delays in transport, diagnostics, or referral can erase the advantage of modern therapy. So the treatment story is both scientific and logistical. The medicine exists, but survival depends on whether health systems can detect and respond before bacterial damage overtakes the patient. Prevention follows a layered strategy rather than one universal fix. Public health guidance emphasizes avoiding contact with dead animals in plague-prone regions, because carcasses may indicate active local transmission and can expose people to infected fluids or fleas. Community education on recognizing early symptoms and seeking immediate care is equally important, since delayed action is a major driver of severe outcomes. Vector control, environmental hygiene, and awareness of animal health trends all help reduce spillover risk. Vaccines against plague have been developed, but broad population use is not typically recommended. Instead, inoculation is generally directed toward higher-risk occupational groups such as some laboratory personnel and healthcare workers. This targeted approach reflects risk-benefit priorities and practical constraints. Prevention therefore depends on matching interventions to context, ecological monitoring where plague is endemic, occupational protection where exposure is predictable, and rapid clinical pathways wherever suspicious symptoms arise. Preparedness works best when it is local, practical, and sustained over time. Modern surveillance confirms that plague did not disappear with the medieval era. Between 2010 and 2015, 3,248 documented cases and 584 deaths were reported globally, with major case concentrations in the Democratic Republic of the Congo, Madagascar, and Peru. These numbers are small compared with widespread modern respiratory pandemics, but they are significant because plague remains highly lethal without timely treatment. Geographic concentration also reveals how disease burden follows ecological and infrastructure realities. Where animal reservoirs persist and healthcare access is uneven, outbreaks can recur. Surveillance data should not trigger sensationalism, it should trigger precision. Health authorities can prioritize high-risk districts, strengthen diagnostic capacity, train clinicians on early recognition, and improve antibiotic availability where cases are most likely. The goal is to prevent local clusters from becoming larger crises. Plague today is best understood as a persistent zoonotic hazard that can be controlled with vigilance, rather than an unstoppable threat or a purely historical memory. History gives plague its scale. The Black Death in the 14th century is widely considered to have involved Yersinia pestis and is estimated to have killed around 50 million people across Asia, Europe, and Africa. In Europe, population losses may have reached roughly a quarter to more than half in some analyses. But mortality is only part of the impact. When vast numbers of workers died, labor became scarce, bargaining power shifted, and wages rose in many regions. That economic rebalancing is one reason historians treat plague as a structural turning point rather than only a medical disaster. It changed inheritance patterns, social mobility, and relationships between landowners and laborers. Earlier, the plague of Justinian in the 6th century disrupted the Eastern Roman world. Later, the third pandemic beginning in Yunnan in the 19th century spread through major parts of Asia. Across eras, plague repeatedly showed that infectious disease can reshape political economies, not just hospital wards. One reason bubonic plague remains a foundational case in epidemiology is that it demonstrates connected risk across species and systems. A pathogen in wildlife, a flea vector, a human exposure event, then clinical disease and possible social disruption. Every link matters. If ecological warning signs are ignored, human cases arrive without preparation. If clinicians miss early signs, treatment starts late. If communication fails, fear and misinformation can spread faster than facts. This interconnected pattern aligns with One Health principles, where human health, animal health, and environment are inseparable. In practical terms, that means veterinary observations, wildlife monitoring, and community reporting can be as important as hospital protocols in controlling outbreaks. Bubonic plague also teaches humility. Advanced medicine does not eliminate old pathogens automatically. Control is earned through surveillance, trust, logistics, and rapid action. The bacterium is ancient, but the lesson is modern. Resilience depends on linking data, ecology, and care before isolated warning signs become systemic emergencies. To close, bubonic plague is neither a mythic medieval curse nor a routine infection to dismiss. It is a severe bacterial disease with known transmission pathways, recognizable clinical patterns, confirmable lab diagnostics, and effective treatment when delivered early. Its danger lies in delay in recognition, delay in diagnosis, delay in antibiotics, and delay in public health coordination. The same disease that once helped transform societies can now be managed far more effectively, but only when systems remain alert. The practical takeaway is clear. In endemic settings, avoid risky animal contact, treat suspicious symptoms urgently, and support surveillance structures that connect local events to rapid response. In global perspective, plague reminds us that small biological events can trigger large historical consequences when institutions are unprepared. But it also proves the opposite. When science, public health, and clinical care align quickly, even historically feared diseases can be contained, treated, and prevented from becoming another chapter of mass tragedy. If you found this helpful, please like this video and subscribe for more explainers.